Hello, guys. A very good evening to all of you. And festivities are here, and I wish all of you happy Diwali. And I wish this Diwali brings a lot of light and happiness into your life. So, yeah, as you know, Diwali has celebrations has already started. So, during this session, you might hear some sounds of crackers going off, right? So, excuse me for that. Anyways, did you guys watch today's match? So how are you all of you guys? Good evening, मोनालिसा, मुरली, सौजन्या, कैसे हो आप सब? आज का मैच देखा आप लोगों ने? Did you watch today's match? So anyways, congratulations for the match as well. We won the match. And I just want to tell you one thing. Specifically, this is for those guys who have started their preparation quite late, right? And there is still time. And if you are feeling you are left out because others have started earlier, then it's not about when you started, right? You can accelerate it towards the end, as Virat Kohli did towards the end today, and you can still make it count because March is still far away. So even if you have started late, you still stand a chance, right? So you need to strategize and make your focus rock solid and keep moving ahead, right? So happy Diwali, guys, and good evening to all of you. So yeah, so that there is the message you can get from there because at one point of time I thought we have lost the match. It seemed quite impossible, and even just before one ball, also when Murli he got stumped again. You know, my heart was in my mouth. But anyways, all is well that ends well. So keep moving ahead, keep preparing, and I did not think you guys will turn up today for the live session because festivities are on. Honestly speaking, even I was thinking, should I keep the live session or not? But see, it's 10 o'clock, so we know whatever festivities we have, they are over by 7 or 8 o'clock. Anyways, so guys, our topic of focus today is endocrinology, and this is the seventh week, and by this week we have covered already 70% of pharma. 30% is remaining, so week by week. Before we move ahead, this is week 8, guys, and anti-cancer drugs. Now see, anti-cancer drugs, I want to tell you one thing. Either you can follow this schedule or this week. If anti-cancer drug is too much of a trouble for you guys, then only drug of choice and side effects of anti-cancer drugs, right? Now remember, whenever you're targeting a competitive exam, you don't have to read everything. Now, if you can, it is good. It is always good to read everything. But it depends upon your priorities, how much time you have left. And if anti-cancer drugs is a bone of contention, right? It's something that is creating havoc for your preparation, then you can take some liberty here because anti-cancer drugs, not a lot of questions are asked for NEETPG. But INI-CET, you have to read all of this. If you're preparing, you're serious for INI-SET, right? If you're preparing for NEET-PG and if you don't have much time, you're worried about anti-cancer drugs, just do, rather than leaving the topic entirely, just do at least drug of choice and side effects. If you have time, then please go through this schedule. And then next Sunday, I will be, I don't think I'll be here. Next Sunday, I'll be in Hyderabad for one-day revision classes there. So it will be difficult. So I'll premiere the video for next week, anti-cancer drugs. So anyways, guys, let's begin with today's questions quickly. Let's get done with it. Let's learn something new as well. So the first question today, a decrease in cardiovascular mortality can be seen with, right? So diabetes, see, in diabetes, I have a hunch, I have a feeling, sooner or later, they are going to ask about cardiovascular mortality related to diabetes mellitus, and there are drugs which can decrease mortality, the anti-diabetic drugs, few of them, couple of them. And I have a hunch they're going to ask sooner or later because a lot of research is going in this direction as to which drugs can actually decrease mortality, right? Okay, just wait, guys. I I forgot to change. I forgot to change the screen. Anyways, yeah, I've changed it. I've changed it. All right. So decrease in cardiovascular mortality. So this is the question. Decrease in cardiovascular mortality can be seen with, right? Your options are GLP-1 agonists, sulfonylureas, pioglitazone, DPP-4 inhibitors. So I've given you four options. And as I was saying, I have a hunch they are gonna sooner or later ask about cardiovascular mortality. Right. So this is something I've taught you. I have even asked in Instagram as well. And see, I keep on asking every day 6 to 7 questions on Instagram, the topic that I gave you, right? So come on, guys, comment all of you. What is the answer? A, B, C, or D? GLP-1 agonists, sulfonylureas, pioglitazone, DPP-4 inhibitors. Now, see, cardiovascular mortality, as of now, what we know about a decrease in cardiovascular mortality, there are two classes of drugs, GLP-1 agonist, and second one is DPP-4 inhibitors. GLP-1 agonist and DPP-4 inhibitors. And the reason is pretty simple. Why do you think they might be able to decrease cardiovascular mortality? So GLP-1 agonist, the reason, sorry, not DPP-4 inhibitor, SGLT2 inhibitor, right? So GLP-1 agonists, because GLP-1 agonists, they decrease weight. And probably this, they can cause significant decrease in weight. And GLP-1 agonists, like liraglutide and semaglutide, they are the drug of choice in obesity. So that could be the reason why SGLT2 inhibitors, they decrease cardiovascular mortality. The reason being, SGLT2 blockers, they produce diuresis because of sodium loss, and because of which they decrease blood pressure, and they decrease blood volume, they decrease congestion, and that could be the reason. That could be the reason why. So cardiovascular mortality, GLP-1 agonist and SGLT2 blocker. So here GLP-1 agonist is the answer. Excellent. So this can be asked. Which of the following is shortest and fastest acting insulin? So insulin is one of the important topics in diabetes mellitus. Insulin is commonly asked in your exams, and duration of action of insulin is quite commonly asked. So which is the shortest and the fastest acting insulin? So come on, guys. So it's not a difficult question. It's not a difficult question. It's an easy one, right? So they do ask which is the shortest acting. So Afreza, excellent. All of you have given the right answer. Afreza is the shortest and fastest acting. The reason being, it is given by inhalational route, and our lungs have a huge network of capillaries, because of which inhalational insulin is rapidly absorbed. So it rapidly rises and rapidly comes down. So it is shortest and the fastest acting insulin. Degludec is the longest. Degludec, it is the longest acting insulin. Excellent. By inhalational we give, and it is longest acting is Degludec. Now, we have a clinical case from endocrinology. A 55-year-old patient was brought to the emergency with altered mental status. On history taking, his son said that he was taking levothyroxine but stopped 2 years back and is taking some herbs now. His blood pressure is 90 by 60 millimeters of mercury. Heart rate is 56 beats per minute. Sodium is 120. Blood glucose is 67. And emergency treatment was started that included intravenous injection of option A, levothyroxine, option B, liothyronine, option C, levothyroxine followed by liothyronine, option D, liothyronine followed by levothyroxine. So what do you think is the answer here? Now, first of all, what are we dealing here with, guys? Right, he was taking levothyroxine. So obviously he's a patient of what? Hypothyroidism, right? He's a patient of hypothyroidism. So what has happened? Excellent. Rahul has given the right answer. So what is developed is mixed edema. Right. And basically the question is asking you, what is the drug of choice for mixed edema? Right. So what is the drug of choice for mixed edema? Levothyroxine, liothyronine, levothyroxine followed by liothyronine, liothyronine followed by levothyroxine. Come on, what do you think? What is the answer? Just commit yourself to one option at least, so that you can learn what is the better answer. Guys, so the drug of choice, basically I'm asking you what is the drug of choice for mixed edema. And See, many of you have given answer D, but D is not the right answer. D is not the right answer. I can use liothyronine. So first of all, try to understand. I can use either. I'm gonna use either levothyroxine or liothyronine. I'm not gonna use both because at the end of the day, both will be the same thing. So I'm gonna use levothyroxine here. Levothyroxine is the drug of choice for mixed edema. Clinically, liothyronine is not that commonly used, guys. Liothyronine is not that commonly used, though it can be used. I'm not saying it cannot be used. It can be used. But remember, mixed edema coma. But it is rarely seen nowadays because people understand. I mean, what is the significance of a disease like hypothyroidism? Why they need to continue levothyroxine? Right? Excellent, guys. Excellent. Another clinical case, guys. Here is a 57-year-old man suffering from asthma was admitted to the hospital with nausea, vomiting, restlessness, insomnia, tremor, mental confusion, fever. He has increased hunger, dyspnea and exhaustion, palpitations, and diarrhea. Lab examination included a free T4 level of 13. Right, T4 is increased. TSH is undetectable. The patient should be immediately started first on propranolol, propylthiouracil, salbutamol, diltiazem. Right. So first of all, so anyways, so you guys have already started giving the answer, and I can see that most of you have given the right answer here. So first of all, what are we dealing here with? Right. What are we dealing here with is thyroid storm. We are dealing with thyroid storm, and in a thyroid storm, all of you have given the right answer, guys. Excellent. All of you have given the right answer. Propranolol is the right answer. Thyroid storm, as soon as the patient comes, the first drug we give is propranolol. And you have to understand the reason why. Why I do give propranolol. The reason being, forget about thyroid storm. Even, in hyperthyroidism, patients are at higher risk of atrial fibrillation. And in a patient of thyroid storm, there would be a very high risk, almost 100% chance of having what? Atrial fibrillation. So just imagine a patient comes to emergency with thyroid storm. He develops atrial fibrillation. And you know what is the problem with atrial fibrillation? Why I'm worried about it? It might jump to the ventricles, cause ventricular tachycardia, fibrillation, and cardiac arrest. He might die because of that. And so that atrial fibrillation will jump onto the ventricles via, what is the gate? I've told in the class. What is the gate? AV node. So I have to block the AV node. So propranolol, the main aim here, the main aim why I give it, it is to block the AV node so that my patient does not die. So I blocked the AV node, I am rest assured he's not going to die of ventricular tachycardia or fibrillation for that matter. Second, what I start is anti-thyroid drug. Anti-thyroid drug of choice is propylthiouracil. Right. So remember, propranolol also inhibits conversion of T4 to T3, but it is not a pure antithyroid drug. In the same MCQ, if I ask you which is the antithyroid drug that should be preferred or started, even if there is propranolol, then go for propylthiouracil. Propranolol is not an antithyroid drug. So guys, remember, they play around with English language in the MCQs, in the questions to misguide you. So you have to answer. You have to understand the question, what they're asking, right? See, he is a patient of asthma, is okay. He's a patient of asthma. Okay, he's a patient of asthma, was admitted to hospital. All right. All right. So I also missed the asthma part here. I'm sorry, guys. So it's asthma. So will not give propranolol. Will give diltiazem. I'm sorry, I missed the asthma part because his asthma. See, I can use propranolol. Basically, my aim is to block AV node. So you can see even I missed asthma, right? So whenever solve a question, read the question carefully. So whenever you block AV node, I can use propranolol or I can use verapamil diltiazem. So excellent, guys. You guys have corrected me. That is okay, right? That's great. So verapamil diltiazem. So I cannot use. So I should be using propranolol here, but I cannot use because the patient is having what? Asthma. So anyways, I want to block the AV node. So if I do not use propranolol, I'm going to use another drug that blocks AV node, that is diltiazem. So basically, I made a trap for you guys, and I myself fell into the trap, right? So जो जाल मैंने आपके लिए बनाया था, मैं खुद फंस गया उस जाल में. So diltiazem is the right answer here. So anyways, so what we learn here is in case of thyroid storm, the first aim is to block AV node. Second aim is to start anti-thyroid drug. Excellent. Right, which of the following drugs should be preferred for treatment of hyperthyroidism in pregnancy? So it's a simple question, guys. Which of the following drug should be preferred for treatment of hyperthyroidism in pregnancy? Option A, methimazole, B, propylthiouracil, C, Lugol's iodine, D, iodine 131. Right. So which one should be preferred in pregnancy? Which one should be preferred? So pregnancy and hyperthyroidism is quite commonly asked, mostly in NEETPG. They love to ask about propylthiouracil and methimazole and their use in hyperthyroidism. Use in hyperthyroidism, right? So is that A, B, C, or D? All right. So excellent, guys. Most of you have given the right answer. Propylthiouracil is the right answer. See, whenever they say only pregnancy, trimester is not mentioned, then you have to understand automatically it is being asked to you guys about first trimester, right? If it is not mentioned. So basically, in any disease, if they ask about pregnancy, trimester is not mentioned, you have to understand it is our first trimester. And first trimester, we use propylthiouracil. Second and third trimester, we use methimazole. Second, third trimester, we use methimazole. Now I'm going to ask you one question. Let me know if you know the answer. What about lactation? What about lactation? During lactation, breastfeeding, what I should use? A or B? During lactation, what should I use? Come on. Because this is something that has never been asked. This is something that has never been asked. Right? It does not mean they're not going to ask you. There is a reason I'm asking you, because this is an obvious thing they can ask you in the coming times during lactation. All right, so most of you have answered propylthiouracil, and I'm sorry to disappoint you. Lactation here, the answer would be methimazole. So if you don't have this in your notes, please add this to your notes and to your cortex as well. Methimazole. The reason being propylthiouracil is hepatotoxic. Now remember one thing. It was an earlier notion that propylthiouracil is not secreted in the breast milk and methimazole is. Both are equally secreted in the breast milk, right? Now, propylthiouracil is hepatotoxic, and that is the reason why that hepatotoxic drug, obviously it would be hepatotoxic for the mother plus for the baby as well, because it is secreted in the breast milk. But anyways, methimazole is teratogenic. Even if it goes to the baby, we're not worried about that, right? So remember the beginning, it begins with P and it ends with M, right? Second, third, as well as this. So I told you, Rajaram, I told you the reason why. The reason is propylthiouracil being hepatotoxic. There were old notions. In older editions of textbooks, you'll find that they used to prefer propylthiouracil. The reason being, it was wrong notion that PTU is not secreted in breast milk. That notion is no longer. It does not exist anymore, right? PTU, methimazole, they are equally secreted in breast milk. But what takes precedence here is hepatotoxicity of PTU, and we go for methimazole. Change this in your notes, right? Like, let's move on to a clinical case. A 56-year-old male suffering from asthma was brought to the emergency with altered sensorium. His symptoms on inhalational formoterol and beclomethasone is progressive, and hence was started on oral prednisolone. His BP is 140 by 90. Heart rate is 110. The patient is unresponsive to verbal stimuli, withdrawn to pain, pupils equal and reactive. Fasting blood sugar is 900. Serum osmolarity is 600. Normal is less than 350. The cause of patient's condition is, right. So so this is a clinical case I've given to you to find out what has happened to the patient. Is it steroid-induced ketoacidosis? Is it formoterol-induced hyperosmolar coma? Is it formoterol-induced ketoacidosis? Is it steroid-induced hyperosmolar coma? Rajaram, no, no, no. See, it's not about the baby's liver being mature or not. I mean, if I have a hepatotoxic drug and if I have a teratogenic drug and in the baby, I'll go for the teratogenic drug in the baby. It's not gonna, create any aversion for us. But hepatotoxicity is a problem if I give to the baby, right? So it's a simple one, guys. It's not a difficult question. So steroid was given, and because of steroid, there is hyperglycemia. It is not monitored, and the answer is correct. D. Steroid-induced hyperosmolar coma is the right answer. So if steroids are given, blood sugar has to be monitored. We have to maintain the blood sugar. Otherwise, the patient can go into hyperosmolar coma. That is correct, guys. Excellent, excellent. I'm really proud of all of you. All right. Similar question. I had posted 120 milligrams of methylprednisolone is equal to how many milligrams of dexamethasone? Right? 10, 20, 30, 40. 120 milligrams of methylprednisolone is equal to how many milligrams of dexamethasone? Now, this is a conversion we had done a lot of times during COVID, right? Because during COVID times, when I had COVID, I went to search for some dexamethasone. There was not any dexamethasone, so I bought methylprednisolone, right? Then I had to convert the dose of dexa to methylprednisolone, and vice versa. Many people they did during COVID. So this is actually not a question of pharma. This is a question of mathematics. It's a question of mathematics, right? So whenever they ask such question, you have to see how many times one steroid is more potent. So if you look at hydrocortisone, so let me tell you this for once and all. Hydrocortisone potency is 1. If I compare that to prednisolone, potency is around 4. Methylprednisolone, triamcinolone is 5. And dexamethasone, betamethasone is 30, right? So here, you have to know this sequence of potency. I've told you this. So you have to calculate how many times is dexamethasone more potent than methylprednisolone. So you have to divide 30 by 5. How many times? 6 times. Right. So dexamethasone is 6 times more potent. That means the dose that are required is 6 times less. So divide 120 by 6, 20 milligrams. So 120 milligrams of methylprednisolone is equal to 20 milligrams of dexamethasone. And many of you have given the right answer. So see, yeah, I have posted. See, before doing the live session, I every day I keep on posting MCQs on Instagram as well, so that every day you get some questions. Those are simpler questions, very simple questions which can be asked, right? Rahul Kapoor, how to approach for USMLE as a final year student? See, USMLE is a different ball game altogether. If you are, first of all, if you are doing USMLE, then do one thing. You can message me on my Instagram. My Instagram handle is doc Pharmaniac. So Rahul, message me on doc Pharmaniac, and we can have a chat about USMLE. I'll tell you the resources and guides and what you need to do and what are the expectations, because USMLE is a pretty long journey. It's a long haul. It is not like NEETPG. So you have to be prepared for that. So you can message me. Dr. Mimi, is this session for FMG? So it's for any doctor, anyone who wants to read pharma. So this session is, I have told you earlier, these sessions, they work in a different way. I have told you in the beginning. So Dr. Mimi, you can go to my first session of General Pharma and you'll realize what this session is about. This session is about breaking down pharma into bits and pieces, covering them every day, 1 to 2 hours. So that's a different thing. Anyways, so Rahul, do message me. I'll guide you, don't worry, right? All right, another clinical case, guys. A 45-year-old patient was brought to the emergency with high-grade fever, chills, difficulty breathing, immediately intubated and was put on ventilator. Chest X-ray was done, bilateral patchy alveolar infiltrates. He was started on levofloxacin and azithromycin for bacterial pneumonia. But after 1 day, there was no change in the spread of infiltrates. So that means what? The antibiotics are not working. Possibly is not bacterial, or It is a resistant bacteria. Two possibilities. Bronchoscopy or bronchoalveolar lavage was done. Cell count of the lavage was shown 33% eosinophils. The patient should be started on. The patient should be started on. Right. Itraconazole, prednisolone, itraconazole and prednisolone, ceftriaxone. Right. So what is this infection, guys? You have eosinophils present here. Right. So what is this? So antibiotics are not effective. Come on. So whatever you feel is the answer. Because in these sessions, don't hold yourself back. Go full throttle. Full throttle and comment on all the MCQs as much as you can. Right. Excellent, guys. Many of you have guessed it right. It's a case of ABPA, allergic bronchopulmonary aspergillosis. And your clue is eosinophils. Eosinophils are high in the lavage and alveolar lavage, and that is because of ABPA, allergic bronchopulmonary aspergillosis. So basically, see what I've done here. I've made a clinical case because nowadays this is how questions are asked. And whenever there is ABPA, allergic bronchopulmonary aspergillosis, I told you what is the drug of choice. The drug of choice is prednisolone, and to prednisolone is the drug of choice. I can add itraconazole. So I can add itraconazole to prednisolone. Drug of choice is prednisolone. Now, what is the role of itraconazole? Why do I need an antifungal drug here if it is allergic or hypersensitivity kind of reaction? The reason being, if I add itraconazole, I will need lesser dose of prednisolone. So in other words, I can say itraconazole behaves as a steroid sparing agent whenever I use it in ABPA, allergic bronchopulmonary aspergillosis. Orally, yes, I can use it orally. No problem with that. If the patient, see, try to understand this. Whenever a patient is able to take drug by oral route, our aim is always to give it by oral route. For example, I'll give you a simple example. Whenever we have a patient of asthma exacerbation, he comes to emergency, right? He is awake. He can, there's no LOC. He can take by oral route. I won't go for IV hydrocortisone. I'll give oral prednisolone immediately, because by the time you put a cannula, start the infusion, it takes time. Oral tablet, we're done with it, right? No, see, here it's not about the fungal infection, it is about hypersensitivity. So if I add an antifungal drug, it is going to decrease the dose of steroid required. And obviously that angle also holds true. Another clinical case, guys, a 67-year-old patient was brought to the emergency with altered sensorium and dehydration. Patient had undergone radical prostatectomy for prostate cancer 3 months back. His serum calcium is raised. Alkaline phosphatase is raised. Which of the following drugs can cause most rapid decline in patient's calcium level? Right. So what is this case, guys? What is this case, first of all? What is this case? What is this case, first of all? Excellent, excellent. Most of you have given the right answer, guys. Most of you have given the right answer. And for those who have not given the right answer, listen why it is not right. See, what we are dealing here with, that prostate cancer, mostly it metastasizes to your vertebra, and it can cause erosion and cause hypercalcemia. This is a case of hypercalcemia of malignancy. Now remember, hypercalcemia malignancy. Those of you who have given the answer pamidronate is not the right answer. It's wrong. C is wrong answer. Drug of choice are bisphosphonates, and I prefer IV drugs. I can use zoledronate or pamidronate. Zoledronate more than pamidronate. Had they asked what should be preferred or used for treatment here, pamidronate would be the answer. But they're not asking what is preferred. They're asking most rapid decline in calcium. Remember, calcium decreased. Decreased calcium, it is maximum with bisphosphonates, but fastest with calcitonin. So hypocalcemia, remember one thing, hypocalcemia as a side effect, hypocalcemia as a side effect can be seen with all drugs which inhibit resorption. Any drug that inhibits resorption, like bisphosphonates, denosumab, raloxifene, calcitonin, all these drugs can cause hypocalcemia. Maximum it is with bisphosphonates, fastest with calcitonin. So here, your better answer is calcitonin, which many of you have given it right. Yes, it is drug of choice in Paget's disease as well. Hypercalcemia of malignancy. Excellent, guys, excellent. Most of you have given the answer right. Another clinical case, let us see here. A 56-year-old woman presented to the OPD with persistent back pain for past 1 week. Dual energy X-ray absorptiometry showed diffuse osteoporosis of the spine, hips, and she's a case of very high risk fracture. This is the key word, very high risk. The physician prescribed calcium and vitamin D supplementation and alendronate 1 tablet daily. Despite following the advice of doctor, she still developed esophagitis. So see, remember, you might follow the advice, take with full glass of water, don't lie down. Still, you might develop esophagitis. Now, if the patient develops esophagitis, I have to stop it. And the patient should be started on. Right, what should be started on? I told you the key is very high risk of fracture. Denosumab, raloxifene, calcitonin, romosozumab. So what is the answer, guys? Yes, come on. What is the answer? So I've taught you this. I've covered this in the lecture. I've taught you. If you have read, you should be able to answer. All right, try to understand. Whenever there is postmenopausal osteoporosis, my drug of choice has to be always oral bisphosphonates. If there is intolerance, then I go for IV bisphosphonates. And IV bisphosphonate is not in the option, right? You might bypass bisphosphonates altogether. If there is intolerance or the patient does not want to take bisphosphonate, patient says, doctor, I don't want any drug of this class, give me something else. Then in that case, what I'm going to use is, it depends upon the risk of fracture. The risk of fracture, it depends upon the risk of fracture. Is the risk of fracture high or very high, right? It depends upon the risk of fracture, if it is high or it is very high. If the risk of fracture is high, I'm going to use denosumab. If it is very high, I'm going to use anabolic drugs. And you know what are anabolic drugs? These are drugs like teriparatide, the PTH analog, and second, the new drug, sclerostin inhibitor, that is romosozumab. So teriparatide, romosozumab, these are anabolic drugs because they increase bone formation. So this is how you deal with osteoporosis basically. Clinically, this is how I'm going to deal with. Now, based upon this, can you answer what would be the answer now? All right, so you might have given the wrong answer. That's fine. But let us now give the right answer. Now that I know how to deal with post-menopausal osteoporosis, right? So anabolics, they're preferred in very high risk. If there is high risk, then I prefer denosumab. So excellent, guys. Excellent. Now you got the answer right. Romosozumab. So remember, where we use teriparatide or romosozumab in very high risk of fracture. In orthopedics, you will study what is high risk of fracture, what is very high risk of fracture. Bone densitometry is done, and bone scan, the bone scan results and other features that they decide is a high risk or very high risk. Excellent, guys. Another case here, see, a 66-year-old patient was diagnosed with type 2 diabetes mellitus The patient had been suffering from chronic COPD basically for 6 years and from hypertension for 4 years. His current therapy included tiotropium enalapril. Which of the following anti-diabetic drug would be relatively contraindicated in this patient? Acarbose, metformin, sitagliptin, glyburide. Right. So this is, I made a clinical case based upon one type of MCQ which is commonly asked about a drug. Right. So it's not a difficult one if you solve those MCQs. So acarbose, metformin, sitagliptin, glyburide. What is the answer, guys? All right. Think at least, commit to one answer. Commit to one answer. Anything that you think might be related here. All right, let me give you the clue here. The clue is COPD. In COPD, why the lips are blue in color, why the nails are blue in color, is because of what? Hypoxia. And whenever there is hypoxia, there is anaerobic glycolysis and formation of what? Lactic acid. So remember, chronic lung disease can increase the risk of lactic acidosis. And there is a reason why your answer would be metformin. So metformin, remember, so this is just I've twisted the information that metformin can cause lactic acidosis. So any condition that can increase risk of lactic acidosis, like a chronic lung disease, like COPD, like destructive pulmonary tuberculosis, like chronic alcoholism, like elderly people, very old people, right? So in these kind of people, I mean, I should avoid because of lactic acidosis. So remember, metformin, two MCQs are asked. One is about lactic acidosis, and second is about a decrease in vitamin B12. Two things you have to keep in mind, and there is a reason why answer is metformin here. It's a very long question. A 22-year-old male was brought to the emergency by police after RTA. He was obtunded and responded only to pain. Medical history from his father was unremarkable. Physical examination showed a patient with contusions to his face, arms, but no signs of cranial trauma. So cranial trauma, so head is okay, right? Blood pressure was a little bit on the lower side. Pulse is a little bit high. Sodium bicarbonate is very low. Glucose is 900. Creatinine level is 1.3. Urine analysis showed the specific gravity 1.303. Glucose is 4. Ketones 4. Which of the following correctly pairs most likely patient disorder with appropriate emergency treatment? So it's not a difficult one. What could have been the possible cause here? What could have been the possible cause here? Diabetic hyposmolar IV regular insulin, acute renal failure, furosemide, respiratory acidosis, IV bicarbonate infusion, diabetic ketoacidosis, IV regular insulin. So it's not a difficult question. If you come down to the end, then this ketones, they give away. The ketones, they give away the answer. The ketones, they give away the answer. It's a case of what? Diabetic ketoacidosis. So see, I just want to tell you something. The reason why I made this question is in exams, whenever you look at long questions, we have a tendency as humans to lose patience. And we have a tendency to think that long questions are difficult. It's not that. In a very long question, you have to find that one or two keywords which give away the question itself, right? So ketones, they give the answer. It is a case of diabetic ketoacidosis and IV regular insulin. All of you have given the answer right, and I'm extremely proud of all of you guys. A patient was started on a drug for treatment of acromegaly, after which he developed visual field defects. The drug that he must have been started on is, a patient was started on a drug for treatment of acromegaly, after which he developed visual field defects. This is an MCQ that was recently asked, last NEETPG. I've changed it. I've little bit changed it because, the topics are repeated. Questions are not. So it's the same topic. So what is the answer now? Come on. This is not a difficult one. It's not a difficult one. It's an easy one. Excellent, guys. Excellent, excellent, excellent. All of you have given the right answer. Some of you have even given the reason. Right. So answer is pegvisomant and pegvisomant. See the last NEET PG that asked you about a growth hormone receptor blocker used in acromegaly, and your answer was pegvisomant. I've just changed it little bit, including a side effect. Growth hormone receptor blocker. Because of that, it causes pituitary adenoma, and because of that pituitary adenoma, compression of optic chiasma can cause visual field defect. So pegvisomant is the right answer here. Pegvisomant is the right answer. Excellent, guys. Which of the following is not a use of goserelin at intermittent dosing? Now remember, GnRH agonist is a GnRH agonist, and here frequently the MCQs which are asked, they try to confuse you between intermittent and continuous dosing, right? Uses of intermittent and continuous dosing. Intermittent and continuous dosing. Anovulation, delayed puberty, oligospermia, sexual infantilism. So it's a frequent. So again, a similar MCQ was asked a few years back in NEET PG. I have just changed it to something else. Right, guys. So what is the answer here? Come on, come on. All of you must comment, guys. All of you must comment. It's not a difficult MCQ. See, you are supposed to do such questions right. You'll have some silly mistakes, I agree, right? But if you do such questions wrong, you're out of the race. See, goserelin is a GnRH agonist. It's a GnRH agonist. So gonadotropin releasing hormones, they cause puberty, and intermittent dosing, GnRH agonists, they're used for precocious puberty, not delayed puberty. So the answer is delayed puberty. Sexual infantilism, we can use it. I've told you this in the lectures. Sexual infantilism is where the person is growing physically, but the sexual organs are lagging behind. Even there, we can use it because the onset of puberty, maturation of the sexual organs, it is because of GnRH, obviously causing release of LH and FSH. So B is the right answer. So it is not a difficult question, guys. It's not a difficult. You should be able to solve such questions. Tamoxifen and raloxifene differ from each other on effect on which organ? Breast, uterus, bone, lipids. Again, it's not a difficult question. It's an easy one. And specifically, I've told you this in the lectures that they do ask you the difference between tamoxifen and raloxifene. Where do they differ? Right? They are similar. They are similar everywhere in the body. There is only one organ of difference between tamoxifen and raloxifene. I've told you this. And they asked this. Excellent. Now the right answers have started pouring in. And the right answer here is uterus, guys. Uterus is the right answer. Most of you have given the right answer. Tamoxifen is an agonist at estrogen receptor. Raloxifene is a blocker at the estrogen receptor at uterus. That is the reason why tamoxifen can cause uterine cancer. Tamoxifen can cause uterine hyperplasia, whereas raloxifene is protective of uterine cancer. This is where they differ. Apart from that, take it, be it breast, bone, lipids, side effects, coagulation, hot flashes, everywhere they go hand in hand. They are similar. The only place of difference where they differ from each other is this one, that is uterus. Right? Excellent, guys. Excellent. Most of you given the right answer. And that's all, guys. If you have any doubts, you can ask me now. The MCQs which I intended to discuss today, I've discussed. And apart from this, if you don't know, then on Instagram, every day's topic that I give you, I post around 6 to 7 MCQs, right, on Instagram story. So every day you will find in story. If you have not done yet, now you can go to something called as, there is something called a story highlight. And in my story highlights, you'll find MCQ1, MCQ2, MCQ3, and in each section you'll find 100 MCQs. These are simpler MCQs from the topics, right? Simpler MCQs from the topic that I asked. Sir, is metformin, so Sriram is asking, sir, is metformin can be used to decrease CVS mortality? See, metformin as such, see, CVS mortality is something you have to find in clinical trials when you compare, right? But CVS mortality as such has not been affected with metformin. It has not been seen. All right, what is the difference? So, all right, Kunjan Dabhuwal is asking, what is the difference between gonadorelin and GnRH agonist and antagonist? See, it's pretty simple, guys. If you have attended my lecture, you'll understand. I explained this from the very basics. That this is suppose hypothalamus, this is pituitary. Hypothalamus, it releases GnRH, right? It releases GnRH, and this GnRH, there are cells here, and these are receptors like GQ receptors. Now this GnRH, it comes and binds to GQ receptors and releases LH and FSH. Releases LH and FSH. Now I can synthesize a drug that is analog of GnRH. This is called as gonadorelin. Gonadorelin is analog of GnRH. I can synthesize a drug which is stimulator of receptor. This is called as GnRH agonist. I can synthesize blocker, that is called as GnRH antagonist. So this is something I've covered in the lectures, guys. Diksha Raj, I'll show the schedule. At last, I'll show the schedule. Mohammad Yasir, thank you very much for the wishes. Happy Diwali to you also. Nitin Akhileshwar, yes, you are correct. See, GnRH, what happens is, if I give GnRH agonist can be given by intermittent and continuous dosing. Now try to understand this. If I give GnRH agonist by intermittent dosing, then every time I stimulate the receptor by intermittent dosing, LH, FSH will increase every time. What happens if I give by continuous dosing? By continuous dosing, remember this is one thing, whenever you stimulate a receptor, continuous dosing, when you stimulate a receptor for far too long continuously, the receptors undergo downregulation. That means the receptors begin to move inside the cell. No receptors are gone. That is the reason why continuous dosing will decrease LH and FSH. So, intermittent and continuous dosing, they are north and south, totally opposite, right? Uses of clinical role of GnRH agonist, antagonist, guys, I've covered this in the lecture. It is there in the lecture, don't worry. Rate of fluid infusion. See, rate of drug infusion, again, I've covered in G Pharma. You're asking me everything that I've taught in my lectures. In G Pharma, I have covered the infusion rate and how do we calculate infusion rate. I've covered this. Everything I have covered, guys. So, Diksha Raj, you can take, if you have joined late, you can take a screenshot of the next week schedules for anti-cancer drugs. This is the next week schedule, and next Sunday I'll not be in Delhi. I'll be in Hyderabad for one day revision class. So I'll do a premiere. So whenever I'm not there, I'll do a premiere, as you know, right? All right, so you can take a screenshot. So, all right, guys, that's all for today. And again, before signing off, a very happy Diwali to all of you and to your parents and your loved ones. And tomorrow is the day, because see, if you are an FMG aspirant, you don't have time to relax because your exam is on December 4. So you can celebrate for 1 to 2 hours in the evening, but then keep studying the whole day. If you are a NEETPG aspirant or INI set aspirant or NEETPG, then NEETPG aspirant specifically, exam is on March. And if you're too much overburdened, right? If you're too much tired, you can take one day off tomorrow, right? Don't be too harsh on yourself. You have earned that one day off. If you want, you can take it, and it is okay. Because the reason being, when you take one day off, you rejuvenate and your productivity increases, right? So what can be a better excuse than a festival like Diwali to relax yourself? But remember it, if you're targeting the INI set exam or FMG exam, it is not advisable. You should at least study half of the day, and towards the evening you can begin with the festivities. Anyways, guys, so this is Dr. Ranjan with you, and lots of love and blessings. Take care. Bye bye. See you next time.